Okay guys, now we're going to move on to chapter 16, which is the chapter on actually giving birth. So, what happens during the birth process and what are the physiologic effects of birth? So, the maternal response is labor contractions are intermittent, they're not continuous. And this allows for blood to still flow between mom and baby, because when a contraction is occurring, then for a brief period of time that placental blood flow is decreased tremendously. So we have to make sure that we're monitoring these contractions during early labor. The upper uterus contracts actively to help push the fetus down, and this is actually what causes the changes in the cervix to occur. And the changes in the cervix include effacement and dilation. Now, this is in your book, and all it is just a representation of an actual contraction occurring. So as you can see, there are three parts or three phases to each contraction. We have an increment that occurs when the contraction begins. We have a peak or an acme, and this is where the contraction is the strongest. And then we have a decrement, which is when the contraction is decreasing in intensity. So the next part we have is duration, frequency, and interval. So duration is just how long each contraction lasts from beginning to end. Intensity is, of course, how strong the contraction is. Frequency is just how often is it occurring. And interval is the period between the end of one contraction and the beginning of another contraction. And everyone's seen this on TV. The first thing they ask you is how far apart are your contractions? Because at first the contractions are going to be fairly far apart. But as we get closer and closer to birth, then the interval between the two contractions is going to get shorter and shorter and shorter until there's no interval at all. We are just contracting to get the baby out. So this slide is talking about the uterine contractions and the opposing characteristics of the uterus. So while labor is going on, the upper part of the uterus contracts actively, and the lower part of the uterus is not. So this is to help push the baby down into the birth canal and out of mom. These contractions also help to elongate the uterus and help to straighten out the fetal body, because when it's inside mom, it's all curled up in the fetal. We call that the fetal position. So we want to straighten baby out so that it's coming out in its narrowest, longest form, coming through the birth canal. Okay, this slide right here is really just to show you or describe to you the difference between cervical dilation and effacement. So looking at the top, we see effacement is the gradual thinning, shortening, and drawing up of the cervix, and it's measured in percentages from 0 to 100. So we can see the first picture, you see the cervix is in its normal place. We have the internal os and the external os, and so no effacement has occurred. In the middle one, we see that we've had some changes to occur. It's starting to shorten and thin out and draw up so we can make room for baby to come out. And then in the last one, we see it's 100% effaced. It's thin, it's short, it doesn't look anything like the picture of 0 effaced. So then we have dilation, and this is just the opening of the cervix as measured in centimeters from 0 to 10. So you can see on here, this is not an actual true-to-life representation of 1 through 10 centimeters, but if you have a ruler handy, and I happen to have a ruler handy, and I measured on screen, and actually the 10 centimeters measures 5 centimeters, so this is about half scale to give you an idea of how much the cervix has to open in order for baby to be born. This is just another illustration showing the difference between a prima gravida, which remember is a woman who has never been pregnant before. This is her first pregnancy. And then a multigravida, this is the picture of a woman who has had a child or several children before. Alright, so the fetal response during this time is that the lung fluid production decreases and is absorbed, getting ready to breathe in oxygen for the first time. And the thoracic compression that occurs from the uterine contractions during labor helps get rid of that fluid inside baby's lungs. So now we're going to talk about the components of the birthing process, and it's the 4 P's: powers, passage, passenger, and psyche. Okay, so powers. The 2 powers of labor are the uterine contractions and the mother pushing. I mean, this is the only person who can physically expel baby out, is mom pushing and then the body reacting with the uterine contractions to help expel baby. So during the first phase of labor, and we're going to talk more about that in a minute, which is just the onset of contractions through dilating to 10, the uterine contractions are the primary force moving the fetus. So mom has a contraction and she tenses up and she feels it, and it lasts for about a minute and then it stops. So she's not actively pushing to get the baby out. It's only during the second stage of labor, which is dilation through birth, that the woman has to use her pushing efforts to propel the fetus through the pelvis. So passage. The passage, of course, is the maternal pelvis and its soft tissues. This is where baby is going to exit out of the womb into the world. So the bony pelvis is more important to the outcome of labor because this is bones and joints. And bones and joints don't want to give. They don't want to yield to the forces of labor. But over the term of pregnancy, with progesterone, we have the softening of the cartilage that links the pelvic bones together. And as we get closer to time for baby to be born, then that hormone relaxin increases, and that helps to make that cartilage more pliable so that the bones can separate and give baby enough room to be born. Alright, this is an illustration from your book. It is on page 322. And it just shows you the different areas of the pelvis and locations and places where changes are occurring during birth. Alright, so our next P is passenger, and of course this is our baby. He's the passenger. He's being delivered. So we're worried about the fetal head, the fetal lie, attitude, presentation, and position. In presentation, it's either cephalic, which is head first, and that's what we want, head first, or it's breech, and breech is when the buttocks or the feet are coming out first, and that is not the normal position for baby during birth. So position, if you look on page 326, it talks about position, and this really is talking about the location of the fetus by describing the location of a fixed reference point in relation to mom's pelvis. Alright, so the fetal head. So we know that baby has fontanelles and sutures that are not fused. And the reason why they're not fused is because baby's head has to fit through mom's pelvis. And sometimes baby's head is bigger than the opening in mom's pelvis. So Mother Nature has designed baby so that these bones can overlap and decrease the size of the baby's head in order for baby to be born. Now, lie just describes what position baby is in. Longitudinal is when baby is in the top to bottom position. Head is down, butt is up. Transverse is when head and butt are going side to side instead of up and down. Attitude, this just refers to how baby's head is positioned and how baby is positioned inside the womb. Flexion is when baby is basically curled up still in fetal position with head down. And extension is when baby's head is up and back, and so we have more of a face presentation. So here you can see why that matters. So with complete flexion, you look and you see baby's head inside mom's pelvis, and there's plenty of room. It's the smallest part or the smallest diameter of the head is presenting first. In moderate flexion, you see baby's head, a bigger part of the head is presenting. So it's going to need a much wider area in order to be able to get through the pelvis. Poor flexion is when we have even more extension, and we're at one of the bigger areas of the head, and then we have full extension, and this is where baby is presenting face first, and that is the biggest portion or the largest diameter and size of baby's head. So these are variations of breech presentation. We have frank breech, which is where the feet and the legs are fully extended up. Baby's basically folded in half with the buttocks presenting first. Full breech, this is where baby's legs are crossed. They're not fully extended. And then we have single footing breech, and that's where one foot presents before the other. This is an illustration of the 4 quadrants in the maternal pelvis, and this is what we would use to describe the fetal position. This is another example of some fetal presentations, and these are on page 327. You can look over those and see all the different ways that baby can present when it's being born. Alright, the next P in our 4 P's is psyche. And psyche is the mother's portion, how she feels about childbirth, or what she's feeling during childbirth, or how she expresses herself during childbirth. And it can be based on culture, ethnicity, You know, women who are really anxious, are fearful, are fatigued, they don't cope with labor pains as well. Mom does release catecholamines in response to anxiety and fear, and they can actually inhibit uterine contractility and placental flow. So it's very important for us as nurses to try to decrease the level of anxiety and fear or fatigue. This would be one of those times when mom's had a really long progressive labor and she's really tired, and you got 20 people in the room asking her 500 questions. You know, this may be a time when we say, let's let mom rest for just a few minutes. There may be someone in the room who's increasing mom's anxiety and fear by reminding her of the child she gave birth to last time who had problems during childbirth, or they had problems during childbirth. That's not the time that we need to hear those stories, especially mom. Mom doesn't need to hear those stories. So the more mom relaxes, the better labor will progress. Okay, cultural values. This tells a woman how she should act or react to labor and how she should interact with her newborn. You know, not every culture believes in, you know, dad being there and woman screaming and expressing her pain and, you know, dad cutting the cord or significant other cutting the cord. You know, we really have to know. And there's a lot of cultures where the husband or the man is not even going to be there with our laboring mom, because that's just not part of their culture. Men aren't supposed to participate in the birth of the child. That's woman's work. So you really need to know the values of your patients, your clients, and be able to see what you should expect when she goes into labor and when she starts having baby, and how she may react or how she may overreact, or things that we might see. All right, so premonitory signs of labor. These are just warning signs that labor is near. So they include Braxton Hicks contractions, which are just mild, irregular contractions. Lightning. This is when baby drops and starts to descend toward the pelvic inlet. I'm sure you've heard many people say this. Oh, look, she looks like she's dropped. She's due any time. She's dropped. And it's just baby is sitting lower in the lower abdominal area, getting ready to be born. You'll have an increase in clear, non-irritating vaginal secretions, and this is just because, you know, you've got pressure on this vaginal wall and this uterine wall, and it's going to cause the outflow of some of these fluids, and that's perfectly normal. Bloody show. This is just a sign that the cervix is ripe, and when we say the cervix is ripe, it means it's soft, it's dilating, and it's effacing. It's starting all of that process. It's ready for baby to be born. An energy spurt. We call this the nesting syndrome. This is where a few days before baby is born, mom all of a sudden feels the need to clean the house, wash all the clothes, get everything ready because she knows that something's going to happen soon. She doesn't know when, but she wants everything to be in place. And then you may see a small weight loss in mom, and this is just because of the changes in hormones that help to excrete extra fluid that mom may be holding on to. Alright, so the difference between true labor and false labor. True labor is we have progressive effacement and dilation of the cervix. Some women don't have symptoms typical of true labor. And so if they're not sure whether or not they're in true labor, then this is when they need to go somewhere and be evaluated. And we need to make sure. And a lot of times mom will come in and it's false labor. She's not in labor yet. She's almost in labor. She may have dilated just a little, 1 or 2, but they send her back home because she has not progressed enough to be considered true labor. Okay, so a question. A pregnant woman is 38 weeks gestation. She wants to know if any signs indicate labor is getting closer to starting. The nurse informs the woman that which sign of labor may begin soon. A weight gain of 1.5 to 2 kilograms, an increase in fundal height, urinary retention, or surge of energy. And the correct answer is the surge of energy, that nesting syndrome. Okay, so the mechanisms of labor. The first part is the descent, and this is actually the fetus moving down into the pelvic area, getting ready to begin that labor process of being expelled from mom's body. Engagement of the presenting part, and this is just whatever fetal part is presenting at its widest diameter. Flexion of the head, we talked about that a little bit before, but we want the smallest head diameter to pass through the pelvis first. Internal rotation, what this does, it allows for the largest part, the fetal head, the largest diameter, to match mom's largest pelvic area or pelvic diameter. Extension of the fetal head, this is what happens once the head passes through the symphysis pubis. External rotation, once the head passes through, then the baby has to rotate slightly in order to allow the shoulders to be in the correct position so that they can come through or pass through the symphysis pubis. And then expulsion of the fetal shoulders and body, and this is just when the shoulders are born, and then usually once the shoulders are born, baby comes right out. Okay, this next illustration is on page 330 to 331, and it just is an example showing you what baby's doing while birth is going on. And normal position for baby to be born is in the face down position when the head is born, so that's a normal presentation. Okay, stages of labor. Okay, so the first stage involves the actual onset of true labor, and it goes through until the cervix is completely and fully dilated and effaced. So the first stage is divided into 3 phases. The latent phase is when labor starts until mom has dilated to about 3 or 5 centimeters. The active phase is from 4 to 6 centimeters, and then the transition phase is 7 to 8 centimeters until complete dilation and effacement. And usually the transition phase is short but intense. The second stage of labor is actually the expulsion of the fetus. The third stage, or placental stage, begins as soon as the baby is born and ends with the expulsion of the placenta. And then the fourth stage is the actual physical recovery of mom and can last anywhere from 1 to 4 hours after birth. This is a representation of Friedman's curve, and it's just a way to see if dilation is progressing at an expected rate, and it compares a multiparous to a nulliparous mom and how things may differ. Okay, this is just a picture of the placenta once the placenta has been born. I'm sorry, I guess not born, but expelled. Alright, so labor progress. So normal labor is characterized by consistent progression of uterine contractions. So that means that they get closer together and they get more intense. We have that cervical dilation and effacement, and then we have the actual fetal descent into the pelvic area. So during labor, the fetus is the more vulnerable out of mom and fetal pair. The fetus is now the one who is traversing a more dangerous path. So one of the things we have to remember is that a normal fetal heart rate is for a term baby is 110 to 160. And in the next chapter, when we talk about how the fetus responds to birth, we'll talk more about how we can look at the fetal heart rate and determine if something may not be right. Okay, so some things that would be associated with fetal compromise or problems with the fetus would be that the fetal heart rate is outside that normal range of 110 to 160. We can have meconium stained amniotic fluid, and meconium is just that first stool that a baby has after birth, and it's supposed to occur after birth. It's not supposed to occur while baby is still in utero, because that gets into the amniotic fluid, and then baby breathes that into his lungs or her lungs, and it can cause problems. If we see cloudy, yellowish, or foul odor to the amniotic fluid, when the water breaks and it's not clear, then we might have some compromise going on with baby. And then excessive frequency or duration of contractions. Incomplete uterine relaxation. So when mom has a contraction, she should also have a period of complete relaxation of the uterus in between the contractions. And then if we have maternal hypotension or hypertension or a fever, then these can cause problems with baby as well. Okay, so we talked a little bit about this. When we have a contraction, there is a reduction in the flow of blood between mom and baby. So that means there would be a reduced flow of oxygen and nutrients to baby from mom, and then a reduction of the waste coming from baby and going back out to mom for her to get rid of. So a maternal supine position can reduce placental blood flow because the uterus compresses on the aorta or the inferior vena cava. So sometimes if we have changes in baby's heart rate, a lot of times we can change mom's position, lay her on her side, put a pillow under her, so that we don't get that compression of the aorta and the inferior vena cava. So when mom is laboring, we want mom to be as comfortable as possible. Mom is the center of attention. If I happen to have been the nurse in someone's room and they're laboring, I don't care that the sister or the husband is cold and they want the heat turned up and mom's hot. We've got to keep the room to what mom wants it to be. And we may not want all of the lights to be on at first. We may want a more calm, peaceful room, lights a little bit dim, so we can help her to relax. We want to make sure she's clean, and that if we need to, we give her mouth care, because remember, she's going to be doing some mouth breathing. She may have been laboring for 12 hours and you get that yuck develop in your mouth. So, we want to make sure that she gets mouth care if she needs it, that she's kept clean and dry. She's able to empty her bladder when she needs to. Now, in the past, way past, when I was born, you had to have an enema before giving birth. And this was so you would not expel stool on the doctor or around the area when baby was being born. Nowadays we don't do that. We would not put a catheter in mom unless there was a problem and she couldn't void. We would want to position her in the most comfortable way. If it's in a chair, that's fine. She may want to be up walking around. Not everybody just wants to lay there for 12 hours waiting for this baby to be born. And, and we wouldn't want that either, because remember, laying in bed and decreased ambulation increases our risk for other things. We want to encourage mom. Tell her she's doing a good job. It'll be over soon. It's progressing. Make sure we let mom and dad, or mom and significant other, know everything that's going on. And also that they know what medications they can take while they're in labor. And this should have already been discussed prior to mom going into labor, is, whether she wanted a natural childbirth or whether she wanted childbirth through chemicals. So that should have been something that's already been discussed with the obstetrician, and so she should have pain medicines ordered. If that's what she wants to do, then by all means don't withhold pain medication. If she says she's in pain, then we need to medicate her. This is just an example of some of the positions that moms may take while they're in labor. Whatever, as long as it's not really crazy, mom can pretty much do whatever she wants to do, whatever is most comfortable for her. And we also want to encourage significant other to assist with this positioning, because we don't want mom rolling off the bed or falling or tripping or anything like that. And we also want to make sure, if there's other people in the room, that mom is not exposed any more than necessary until it's time for baby to be born. So keep that in mind. And also keep in mind, when you're having to do checks on mom, pull the curtain. Most of these birthing suites now have curtains you can pull so that family's on one side and you're doing your checks on the other side, and as soon as you get done, then you can pull the curtain back, and mom's not left alone by herself. Okay, so you as the nurse must be alert for signs of impending birth. And that may be mom saying the baby's coming. She's grunting, she's bearing down, or she has the urge to bear down like she's going to have a bowel movement. You need to check and see if the head is coming out. If mom does a push and baby's head starts coming out, then we may want to tell mom not to push for a few minutes until we can get the obstetrician into the room so that he can be there to deliver baby. One of the things to remember during this time of birth is that mom's been through a lot for the past few hours, and her temperament may have changed since early labor. She's tired, she's hurting, she's ready for this to be over. She may be short and curt with dad or significant other. And we have to understand and make sure that family members understand that this is normal. This is not going to last. She's tired. She wants to get it over with. So anything that she says, don't take it seriously. I've heard stories of moms cursing out dads, when birth was imminent. It was about to happen, and she's screaming, "Don't you ever touch me again. We're not ever having another baby," and things like that. So we need to reassure dad or significant other that it's going to be okay. This is normal. She's not really mad at you, but, she may say some things that aren't really nice while the baby's being born. Okay, so what are our responsibilities during birth? Well, we have a lot of responsibilities. First off, when moms are laboring, it's usually one-on-one. You have a nurse in the room, and she stays with you throughout your labor. She's checking you. She's checking how mom is progressing. She's looking at how baby is tolerating labor. She may be prepping areas for a sterile table, especially if they think that there might have to be an episiotomy, because that is a sterile procedure. So if we had to put some type of monitoring device in utero on baby, such as on baby's scalp, that's a sterile procedure. We would also be responsible for cleansing the perineal area and getting it ready for birth. The delivery nurse is going to be there, and there's going to be someone designated to take on the initial care and assessment of the newborn. There are certain things that have to be done once baby's born to make sure that baby is healthy and doing well, such as Apgar. We may have to administer medications such as oxytocin to contract the uterus and to control blood loss. So we have a lot of responsibilities there. So just be aware that you may be a jack of all trades in or during the birth of a baby. So this is just an illustration of the sequences of delivery that occurs and how the obstetrician will help manipulate baby and protect baby when baby's being born. In the second picture on the top row, you see they have like a cloth to help wipe away any secretions that occur to keep them from getting on baby's face, especially if mom were to expel some stool during birth. We would not want that to get into baby's airway, so we have to protect it. The obstetrician or the midwife has to look and see if where the cord is, if the cord happens to be wrapped around the baby's head. Things to look for, and we talked about that before. That's why baby's head is born first, so that if the cord does get compressed, then baby's head is already out and baby could go ahead and begin breathing and not be relying on mom and the placenta and the umbilical cord in order to meet their needs. This is just a picture of an actual birth, and on Blackboard I have posted some YouTube videos that show actual birth. There's also a breech birth, a spontaneous breech birth. There is a video using a suction device in order to facilitate baby being born. So I encourage you to watch those videos if you have not watched them yet. Alright, so once baby's born, we have two people to care for now. We have people to care for the infant, and we have people to care for the mother. You're normally not doing both. You usually have one job, and that would be either for the infant or for the mother. With the infant, we've got to make sure they're breathing. They're breathing normally. We've got to make sure that they're warm, because for a little while after birth, they have a hard time regulating their temperature. They've been in this 97.6 degree space and haven't had to really manipulate their internal thermal regulation. But now that they're outside, and especially in a lot of surgery suites or birth suites, it's usually kind of cold in the room. We also have to identify the infant. You would immediately put a band on the infant that matches the band of the mother, in some way has the identifying information, because we've all heard about it. Babies accidentally mixed up during birth. You also have to make sure that you document if there are multiple babies, which baby's born first, when each baby is born, because remember, in a lot of cultures it's very important to know if there are two boys born, which one was born first, because the firstborn is treated differently than the secondborn. Care of the mother. You've got to make sure you observe for hemorrhage. You've got to promote uterine contractions so that we can expel the placenta from the uterus. We also have to promote parent-infant attachment. And usually what happens is as soon as we determine that baby is normal, he's breathing, we get him cleaned up, wrapped up, we want skin to skin. We want baby lying on mom's chest. We want to go ahead, and if baby is sucking, we want baby to go ahead and attach to mom's breast. So we really have to promote that parent-infant attachment just as soon as baby's born, if that's possible. Now, that's not always possible with complications, or if mom's had to have a cesarean and she's in the surgical suite. She may get to see baby for a brief second, but then baby is whisked away to the nursery. And that's normally when, if mom's okay, then we would tell dad or significant other to go with baby. And we got to make sure also that dad or significant other has the same identifying bracelet on, because most maternity wards are locked units. You cannot come in unless you are buzzed in. Babies have monitors on them that if you get too close to a door, the alarm will sound and everybody comes running because they think you're trying to abduct an infant. And people do that, and that's one of the reasons why we have that now. You know, when I was little, the big thing, because my mom was a nurse and we would go to where she works, we would go up to the mother-baby floor, and we would go and look through the window at all the babies in the nursery. Well, that's a HIPAA violation. You can't do that. You can no longer go and look at all the babies in the nursery. First off, all the babies aren't in the nursery anymore. We want babies to be with moms, and that attachment and that bonding occurring. Only if there's a problem with either mom or baby would baby not be in the room at all times. And normally baby does not leave sight of mom. If at all possible, baby is not whisked away and taken to the nursery, and mom can just chill out for a little while. We don't do that anymore either. So we have to make sure that we secure the safety of the infant and of the mom, and make sure that only people who are supposed to be there are in the room, are holding the infant. Normally, if the infant or the newborn has to go out of the room, then they have to go in their little isolette, and that's the little place where the baby lays. Everybody's seen one. It's on wheels. You can roll it down the hallway. But you can't just walk out into the hall with a baby in your arms. Baby has to be in the isolette. So there's a lot of things to remember. This is why OB content is not heavy on the NCLEX, because this is considered a specialty. And this is just showing, you know, baby's been born. You can see this is a newborn. They've attached a heart monitor. Baby may or may not be under a heat lamp to keep them warm, but they're going to identify baby. They're going to make sure he has a leg band, or she has a leg band on, that identifies who the mother is, who the baby belongs to, so that we can make sure we keep moms and babies together. Alright, we're not going to do chapter 17 yet. That will be another lecture. Thanks.